Hi, everyone. Good evening, and welcome to our Woo You event and virtual crew, where tonight we are going to be having a very fun event. So, we're starting with 1 hour of COPE approved CE presented by the one and only Dr. Gellies. And of course, he's talking about his specialty, technologies in corneal disease. After that, we will get into all the amazing things about CRU. If you haven't been to the meeting, Dr. Gellies and I are going to talk a little bit about it. And then we're going to finish with a really fun virtual wine tasting. So this is a really fun and exciting event to be a part of. So we're really happy that you're here. My name is Dr. Stephanie Wu. I will be the moderator for this evening, and I am the founder of Wu University. So this is a 1 hour CE, so you must be online for at least 50 minutes. If you need a COPE certificate, please make sure to fill out the survey link that's going to appear in the chat box right now. If you can't find the survey link, don't worry. When this webinar ends, it will direct you to the survey, so don't worry if you can't find it or forget about it. We will also email you your certificates and we will send it to Arbo on your behalf if you did provide us with your OE tracker number. I'm not sure if we have a QR code for tonight. If we do, then you can load that into your OE tracker app. And then if you haven't gotten your certificate within 4 weeks, please email us so we can figure out what's going on. And if you have any questions for Dr. Gellies tonight, please make sure to use the chat box or the Q&A that you see on your floating screen. If you are joining us with your phone, you can find the Q&A at the top there in that little white little button. And then with those little three dots on the bottom, that's where you can find the chat, which is where Jenna is going to be displaying all the links for the pre and post test in case you need that for your state license, and the link to the survey as well as the handouts for tonight. And Dr. Gellies, I will let you take it from here.
Awesome. Thank you, Steph. Excellent. So let me go ahead, share this screen, as this is going to be a fun one tonight. I think we'll have a pretty good time with this one. Uh, technologies, corneal disease, we're going to cover just about everything. And this deck has got about 140 slides in it. So we're going to have a real fun time just going through this, and we'll get to what we get to. But, no matter how far we get into it, you're going to have some things that you'll learn and some things that are pretty cool and upcoming. So let's get into this. So really, I'm going to go through a few things in each one of these categories. We're going to go what to do. So what's kind of today in your clinic? What's new, things that you could consider for your clinic, and then what's next? What's coming down the pipeline? What are cool things that are being done? What's new in surgery? All these sorts of things, so that we kind of get, a nice round idea of what's going on out there. I'm going to talk a lot about devices up front, and then we'll kind of get into surgeries and different forms of keratoplasty, things with cross-linking, those sorts of things. But in general, as I talk about devices, everything that I'm going to talk about are kind of universal metrics, things that you could use on every single device out there. Um, one thing that you need to know is that if we're comparing metrics, if you do it on the same device, it'll work very well. Obviously, it'll be very repeatable and accurate. But if you're going from, let's say, a Zeiss device to, an Oculus device, the metrics may not transfer one to one. So just keep in mind that you need to be using the same device. To be able to get accurate, repeatable, comparable data. Your scan quality really matters, garbage in, garbage out, and let's get boogieing, okay? Topography. We're going to start off easy, basic. We know about corneal topography. Basically, we're using this as a method of measuring the curvature of the cornea, and it works off of a reflection of those mires on the cornea. What we do, we take a photo, we use an algorithm to go ahead and measure the spacing between those rings to be able to tell, okay, this is a nice round cornea, or this is a aberrated or distorted irregular cornea. If you got nice round rings like what you see on the left, you got a normal cornea. You got warped Meyers on the right. That is going to be what you're going to see in a patient with keratoconus. Um, Now, the importance of looking at the Myers in corneal topography is that the Myers are going to tell you the quality of the scan that you're going to get. So this is an individual who has a poor tear film, and you can see how those Myers are horribly distorted. And when my topographer, the software tries to turn this into a heat map, we lose the ability to be able to see that nice, beautiful colored axial map that's going to tell us all the curvature, right? So if you're looking at the Myers, you want smooth. If you got smooth, even Myers, you know that you got a normal tear film. If you got broken, irregular Myers, you got a tear film issue. Now, some topographers have kind of taken this as an advantage, and they're using it for objective evaluation of the tear film on the cornea. So what are some tips to get some good scans on this, right? One of the things we want to look at, kind of tilting your head to get into the right position to kind of open up the orbit. I'm going to look purposely right at the camera instead of at my screen so that you kind of get the idea here. If you're looking at me straight on, what you're going to see is that my orbit is actually faced out here, right? I'm lateral. What happens is my bridge of my nose and the orbital rim here is going to block my superior nasal area of my cornea from being well imaged if we're using a large diameter cone topographer. So a trick for this to be able to get the widest image and get the lids entirely out of the way, everything like that, simply going to turn the head and tilt the chin, right? So you really want to use your pitch and yaw here. The idea there is to get your orbit from facing out this direction to facing that direction. Okay. Now, when you're holding lids, a big thing on this one is not putting pressure on the globe. Make sure that you get some blinks before you capture. If you put pressure on the globe, the thing that'll happen is you'll distort the cornea, actually. Um, so think about that when you're, trying to hold lids with swabs or other sorts of, instruments. You don't want to put pressure on the eye. You just want to make sure that you're pulling the lids out of the way. Um, Blink before you capture and then hold. Basically, you'll have patients go blink and then open and then hold. If you have to add artificial tears to get that mire to show up, because the cornea is just so dry, use a thin artificial tear or just use a little bit of saline. It seems to work very well in our practice. When we look at this, there's a bunch of vital parameters we can get out of this that are relevant to contact lens fitting, but also understanding the cornea in general. Your white to white, your angle kappa, basically your difference from center, a geometric center of the cornea or corneal apex, and your line of sight. And then you have your keratometry values and your eccentricity values. Eccentricity being a measure of how quickly or rapidly that cornea flattens out as it gets towards the periphery. Other things that you need to know, axial versus tangential maps. Kind of think of this as axial maps are the classic one that we all use and know. Think of that as kind of smooth mapping. We're using it to kind of get a generalized idea of the corneal shape. Tangential, what we're doing is we're looking at the fine details within the corneal curvature. So we're getting a more exact look at the cornea. So these are two examples. I believe this is a patient who's wearing a MiSight soft lens. And what we're looking at is on the axial map, you can't really see the details of the optical profile on the front of the lens. But once you go to the tangential map here in image B, you can see all those details. So there's a variety of things that you can get from topography over a contact lens. You can look at, the positioning of the multifocals or the toricity, or look at low or high eccentricity. And you can see that in even more detail when you go to the tangential maps. But you also got to keep in mind your scales. You want to make sure that your scales are apples to apples here. You can see that if my scales are off, or I have, different types of scales here, I can make an eye that has a lot of cylinder, like on the bottom, look like it has very little cylinder, like in the center, or I can have somebody who has very little cylinder and I can make them look like they have a lot of cylinder, right? So the topography scales are very, very important to pay attention to when you're looking at these maps. For instance, this is the same keratoconic eye. If you look at this, you'd go, oh, the map on the left, map A, is a much worse case of keratoconus than map B, but same eye, the only difference is the scales. So don't trust just the heat maps. You got to know what your scales are that you're looking at. Subtractive maps are going to tell you, what are you doing to a cornea, right? In the left image here, this is the original map, and then this one is where we put a custom soft lens to mask the corneal irregularity in keratoconus. And what you can see is that it evens out the corneal map. And if we look at the difference, we can see just how much we flattened out the cornea or smoothed out the corneal shape by putting that lens on. Over here on the right-hand side, you can see the difference map of a patient wearing an orthokeratology lens. So you can see their pre-treatment map and then their orthokeratology tr or in treatment map, and the differences between the two. In tangential, you can really get a good idea of where that lens is centering. Now, one of the main things that we're going to do in corneal disease and corneal topography is look to diagnose things like keratoconus. Really, what we're looking at with this is looking for irregularities in the cornea, asymmetries, and skewing. So, when we look at our K values, we're looking for any point on the cornea that has a keratometry greater than 47. So, for example, if we were to look at the central cornea, we'd see 44, whereas if we look for the steepest portion of the cornea, it's 54. Now, why does this matter? Because keratometry, stim Ks or autokeratometry, all comes from that central 3 millimeters. So if we were looking at that, we'd say, 44.5, this is a pretty normal cornea. But if you look at the topography map, you can see the K max 54. That's a very steep cornea. We obviously have keratoconus. The next one is something called IS, or inferior superior ratio, where we're looking at the differences from the top to the bottom of the cornea, looking at that asymmetry. If we look at that, a normal cornea is going to have less than a diopter and a half of asymmetry. In this case, obviously, we have keratoconus. They have an IS ratio of 13.3. The next one is looking at skew. When we have astigmatism, the apices of our astigmatism should be in a line and we should have symmetry that is perfectly perpendicular, right? When we look at this, what we're looking for are, do our apices align, or is there a skew in the axis here of those apices? So let's do this. We're going to go ahead and draw some lines here. So the apice on the right goes perfectly horizontal, whereas the apice on the left has an oblique angle to it. Now, when we look at that, you can see the angle that's created there, that is axis skew. And when we look at axis skew, if it's greater than 20 degrees with a diopter and a half of corneal cyl, we should start thinking keratoconus. Now, tomography, we all know from doing OCTs, right? Or retinal OCTs, I should say, these days. So we know what that looks like. It's cross-sectional analysis of tissue with light. And we can apply these tomography principles to cornea as well. We can look at cross-sectional imaging and putting those together to be able to give us multivariable analysis of not just the front of the cornea, like what we get in topography, but the front of the cornea, the back of the cornea, and the global thickness of the cornea. Now, there's two main technologies that we'll use. There's Scheimpflug and OCT. You're seeing Scheimpflug up there. And what you're seeing in these maps are maps of the anterior curvature on the upper left, the anterior elevation, the posterior elevation, and then on the bottom left are global corneal thickness or global pachymetry. So this is going to give us a lot of detail to be able to analyze. Kind of imagine we now have many more metrics that we can look at in these corneas. The two main technologies that we use these days, Shine Flood, kind of lower resolution, gives you a lot of corneal metrics. OCT, which gives you higher resolution, mostly is going to give you thickness measurements, but newer devices are starting to incorporate, axial curvature, elevation of the anterior and the posterior. You start to see these being incorporated in multiple new devices that are out there. So we can get a ton of different metrics. But in addition to the curvatures and elevations, we can also measure corneal clarity by looking at opacity, or rather hyperreflectance within the corneal tissue. Um, we can also look at various different ways of looking at thickness of the cornea. So we're not just looking for the thinnest point, but we're also looking at the distribution of thickness as it goes out. We can see the profiles of cornea very easily. Up top, you can see an oblate cornea in a patient who had RK done. In the center, you can see a normal cornea with a prolate short profile, and then a keratoconic cornea, which has a hyperprolate profile, very, very steep in the center and then flattens out rapidly in the periphery. Again, we can do subtractive mapping of this, but we can do it beyond just curvatures. We can now look at variety of different maps, but the main one that we like to look at in our clinic is going to be looking for edema in the corneal thickness, right? Or rather, the non-curvature maps that we're looking at. The main one that we like to look at is corneal thickness because we can see swelling or edema, which can be induced by a variety of different conditions, whether it's an endothelial condition like Fuchs, whether it is, a patient who is wearing a scleral lens and has induced graph edema. We can, kind of monitor the corneal response in, to therapies or to lens wear. So if we're going to diagnose keratoconus, since that's one of the most common things that we're going to do in clinical practice, what are we looking for? Well, we use the same metrics on the axial map, but now we have the anterior and the posterior elevation maps. So the anterior in the red, the posterior in the blue. The posterior is always a mirror of the anterior, but more severe. So what we're going to see here, this is a cross-sectional view. This is kind of helping you understand what a best fit sphere is doing. When we drop a best fit sphere on the cornea on the front, you can see that we're trying to connect as many points of the cornea through that best fit sphere as we can. So what you're seeing here is a portion. If we had a normal cornea, it'd line up perfectly. But in an irregular cornea, like keratoconus, we have a portion of the cornea that's going to pop above the best fit sphere, and then a portion of the cornea that's going to dive below it, right? If we do the same thing on the back side, we're trying to get as many points to line up with the best fit sphere as possible. You can see that there's a portion of the cornea that pops above it, portion of the cornea that dives below it. And what that leaves us with are these little caps here, right? These little protrusions up through the best fit sphere and these little depressions underneath the best fit sphere. So what we get are these island sort of appearances, these hot spots that are created with this moat around it. And that's what we're looking at that's very pathognomonic with keratoconus. On the anterior side, we're looking for about 15 microns of elevation through a best fit sphere. On the posterior, 20 or more. When we look at the global pachymetry, our main thing on this is looking at the thinnest point on the pachymetry, right? And what they find is actually a thinnest point of less than 500 is associated with subclinical, or excuse me, associated with keratoconus. But 500 is kind of that cutoff between is it normal, is it early keratoconus, which is actually kind of a thicker pachymetry than most people think of. Many individuals will see patients who, may be considering refractive surgery and have a corneal thickness of, 490, 480, and we'll go, you know, they actually still might be a candidate for PRK. So there is this kind of, overlap between when is it, subclinical keratoconus and when is it just a thinner normal cornea. So how do we determine that? Well, we'll talk about corneal biomechanics here in just a little bit. But the big thing that we want to focus on is just a couple of examples here so that you know how to read maps pretty efficiently. So let's take a look at this. This is a normal cornea. Really what we're looking at, if we're just going to break it down into simple pattern recognition, This cornea has no metrics that are over that 47 diopter area. We have, a zero point 0.6 on our IS ratio, our asymmetry. So this is a very symmetric cornea. There's no focal elevations on the front or back. The thinnest point is around 560. In this case, really what we want from our pattern recognition, just looking at this is a symmetric, non-elevated, thick cornea. This is normal. Now, when we get to the keratoconic cornea, let's take a look at this. Yeah, we have Ks over 47 diopters. We have axis skewing of 30 degrees. We have asymmetry from the top to the bottom of the cornea of about 3 diopters. We have areas of focal elevation that's happening at 20 on the front, 50 on the back, and a thinnest point about 470. So, yeah, this is asymmetric. It's steep, it's elevated, it's thin. So that's keratoconus. But what about this patient, right? This is a patient where we go, is this keratoconus? If we look just at this axial map, we may be tempted to say, hey, there's nothing really over 47 diopters. Sure, there's a little bit of axis skew, but, we're looking relatively normal here, but we got a Kmax of close to 47. We have an axis skew of about 40 degrees, but we don't have enough astigmatism to be able to say, oh, that's something that we're concerned with, right? Remember, we needed a diopter of a half of astigmatism to say axis skew is, worth looking at. If we look at the front elevation, we have about 9, but on the posterior side, we have almost 30. And when we look at the thinnest point, we have about 490. So when we look at this, well, it's a little steeper, it's a little asymmetric, it's elevated, and it's thin. So yeah, I would say that this is keratoconus. And the only way we're really truly making this diagnosis is by using corneal tomography. Now let's get into OCT, right? OCT, higher resolution, gives you layer analysis. We're able to look at epithelium, we're able to look at stroma. In the future, we'll be able to go ahead and, really tease out the individual layers, looking at Bowman's, looking at Decimays, looking at endothelium, all these different sorts of things. But for now, we're kind of limited to just really looking at epithelium, stroma, and overall thickness. So, we know we can use this in contact lens evaluation, but what do we want to look for if we're looking for things like keratoconus, right? If we have a normal cornea, like what we see in the top images here, right? We're going to have a nice even sheet of 50 micron epithelium all the way across, right? If we have keratoconus, what we end up with is epithelial redistribution. Kind of think of epithelium almost like panel fill for a car. We have a dent in the car. We're going to use panel fill to just fill up that dent and then smooth out, let's say, the door or the fender or whatever, right? In this case, epithelium is going to try to smooth out the corneal shape to try and get us a more dome shape, right? So if we look at this keratoconic cornea, what we're going to see is we're going to look at the apex of the cornea right here. And what we're going to look at is first where the stroma is, right? That's the anterior stroma. And then we're going to look at the epithelium here, right? You can see where the apex is, the epithelium thins out, and then around the base, it thickens up. And that's to help mask that irregularity. So when we're masking that irregularity, what we're going to see is if we look at the overall tomography here, what we see in the full pack imagery map is we see a thin spot, right? Obvious, we have keratoconus, there's going to be a thin spot there, right? But what we also see is when we go to our epithelium, we're going to see that there's a thin spot that corresponds with the overall thin spot, but we're also going to see epithelial hypertrophy, this steepening or rather thickening of epithelium around that thin spot of epithelium. And you can imagine this is something that we call the donut pattern, right? So we're seeing this epithelial donut sort of shape. So what are we looking for that's kind of, oh, this could be problematic? Well, we're looking for variations of max to min of the epithelium of about 10 microns. That's where we start to say, oh, that's kind of abnormal. We shouldn't see, more than that. So that's really what we want to be looking for. So, how do we use this in clinical practice? Well, let's say you have a patient who has a myopic shift after LASIK. Why are they having it? Well, it's because their epithelium is thickening, starting to stack in the area of, the ablation, right? So the ablation creates a tabletop sort of profile to flatten out the cornea to move that focal point back to the retina. And what we have is over time, as that epithelium tries to smooth back out that cornea, it's going to stack in the middle again to try and round the cornea out, right? So what we're going to get is, in this individual, for instance, they had a -10 correction. This is what we saw him at in 2006 or 2007. And this is what their cornea looks like in 2019. You can see that our cornea looks like it's steepening up, but it's not actually steepening. This cornea is not getting any thinner. What's happening is the epithelium is just stacking up in the center, and we're getting that myopic shift, that hypertrophy. Well, what about in keratoconus? Well, we already went through that example, but what you can see here is we get this epithelial donut pattern, and that is trying to mask that irregularity to try and smooth out the cornea. What about in orthokeratology? What are we doing in orthokeratology? Well, really what we're doing is we're manipulating the epithelial shape, right? So if we take our nice even 50 microns of epithelium, we put our retainer on, it's going to go ahead and create that mid-peripheral thickening of the epithelium and thinning of the central epithelium, and we end up with a profile that looks like this, right? Well, we're getting a donut pattern. What else did we get a donut pattern in? Keratoconus, right? So what do we need to be able to do to follow changes? Well, you need, excuse me, some of the devices that are out there, and what we really need to do is to separate out the stroma from the epithelium, because our stroma should stay essentially the same, but our epithelium will change, right? So we really want to monitor what's happening in the stroma. Is the stroma thinning? That's really what we're looking for. Now, how do we use this in clinical practice? Well, we can use it for refractive surgery. If we have a cornea that looks pretty normal, we're not concerned at all, those individuals would be a candidate, assuming that they don't have too much refractive error, but they would be a candidate for a corneal-based procedure like LASIK, PRK, or SMILE. If they have a cornea that is abnormal, what we would do is say, okay, well, we can still give them potentially refractive surgery, but it's got to be done with a non-corneal based approach. So we got to use either an IOL or an ICL to be able to get that individual the correction, right? Well, I use the exact same approach for myopia management, right? If they have a totally normal cornea, I got no concerns. They can have orthokeratology for my myopia management strategy. If, however, they have an irregular cornea, then I'm going to go ahead and say, hey, not a good candidate for orthokeratology. We're going to go ahead and look at defocus contact lenses or defocus spectacles, right? So multiple targets, there's multiple techniques. We can use these technologies to help drive the way we're going to treat an individual. So what's new? Well, what's coming out, this is available outside of the US, but will come out in the US hopefully next year, is the use of ultra high resolution OCT. So this is spectral domain OCT that has a 1.9 micron resolution, and it uses a wide angle paracentric scanning. So you get full resolution across the entire cornea at a 15 millimeter scan width. So when you use telecentric lateral scanning, like what we do in most OCTs, what we lose is resolution in the periphery of the cornea. But in this paracentric scan, this wide angle parametric scan, what we're getting is high resolution all the way across the cornea. So when you see these images, you are going to lose your absolute mind. So up top here, you can see a Scheimpflug tomography image. In the middle, you can see kind of the real OCT image. And what you can see here is the corneal zoom image. Now, this is basically like an in vivo corneal biopsy, right? So we know what corneal biopsy looks like. How about that, right? We can see our epithelial layer, we can see our Bowman's layer, we can go ahead, we can see our entire stroma and our changes from anterior with our, our lamellar interweaving and then into our orthogonal and then into stacking in the posterior. And then we can see our decimes and our endothelial cell layer. Isn't that wild? So let's go ahead and show you an example of looking at what this does in the peripheral cornea compared to a standard OCT. So when we use this wide angle paracentric imaging, you can see how detailed the peripheral corneal data is versus the loss of data that happens with a standard OCT, right? We lose the resolution in that peripheral cornea, whereas we maintain that in the ultra high resolution. And take a look at this. This is just unbelievable in the corneal imaging. What you can see here is the Scheimpflug image here, whereas you can see the ultra high resolution here. And you can see we were going, oh, well, would this individual be a good candidate for a PTK, right? Because they keep having recurrent corneal erosion. Well, no, they're not really a great candidate for this because you can see that the damage is not just a basement membrane issue. This is a laceration that happened into the cornea to a certain, substantial depth. So if we were going to do, a 50 micron PTK here, we would still have areas of damaged stroma beneath it. But we can see we would have to do a very substantial PTK there to be able to get below that. And this is just the comparison of the ultra high resolution versus the standard OCT, right? Again, you can see just the details here, the Bowmans, just all that, hyperreflectivity and the rearrangement of that, the stromal lamellae and fibrils. Just incredible detail here. And here's an image of an individual who actually had subclinical keratoconus. But when you look at it on the ultra high resolution, it makes it very, very easy to see, right? We can see the elevation in the posterior stroma. We can see the thinning of the epithelium. But what we can also see, which you can't see on most OCT systems, is actually a little bit of thinning in the Bowman's layer. So this is again a change that will be something that we see in the future. So let's get into corneal biomechanics. This is kind of an interesting thing. We can look at the weakness or the stiffness of the cornea to determine, hey, is this normal? Is this abnormal? So we all know about using ORA, right? It gives you two different metrics, corneal resistance factor and corneal hysteresis. Basically, you're looking at rebound and elasticity. These factors, though they can be very good grossly, right? We can tell the difference from, a normal cornea to frank keratoconus. It's very difficult. They're not sensitive or specific enough to differentiate a subclinical keratoconus from a normal cornea. But newer devices exist internationally and coming to the US that are going to be able to look at corneal biomechanics in a much more sensitive and specific way. One of these is Scheimpflug deformation or waveform, deformation. What they're doing here is very much the same sort of thing as an ORA, where you're hitting the cornea with a pneumatic force and you're watching how the cornea deviates from its normal shape. What you're seeing here is we're able to see the movement of this cornea with ultra high speed Scheimpflug. So what you can see is the deformation of the cornea here. You can see the normal eye versus the keratoconic eye, and you can watch the normal eye resists being deformed. It's strong, it holds its position, and then it pops back into shape very quickly, whereas the keratoconic cornea flushes down real quickly, jostles quite a bit, and then has a very syrupy, slow recovery, right? We know that that is biomechanically weaker. But there's a variety of different metrics that come along with this. One of them that is most associated, that's most associated with keratoconus is the AT1 value, which is how fast a cornea applanates, first applanates, right? And you can see that difference right away. These actually are timed out to the same point. So you can see when that air puff first hits, you can see how fast that cornea applanates. So that's one of the main metrics there. Now, what you can do is you can actually use this for ectasia risk for individuals, where you can say, okay, your cornea looked normal, but your biomechanics are a little weak. If we combined those two metrics together, what is our risk of having, an ectasia event afterwards? So there is actually an online calculator, in the United States. This doesn't exist, where we have this combination of these two factors, where we can add our, shape factors from our tomography to our biomechanical factors from our waveform. But outside of the US, there is a calculator that exists, that is an AI-driven software called Brain. Brain, you upload your tomography and your biomechanic data to it, and it'll give you that risk analysis. So very cool. Now, there are new biomechanical methods out there. Brion spectroscopy, which looks at photon scatter, OCT elastography, which looks at compression modulus, and then PhD OCT, or OCE, which looks at phase shift, right? So when we look at this, so what are we really looking at? Brion, this is really new, just got FDA approval in the United States, but what it looks at is optical scatter in various different tissues to be able to, infer elastic modulus. Now, the cool thing about this is it's non-contact, right? Whereas when you look at the other biomechanical measurements, whether it's ORA or it's looking at that Scheimpflug biomechanics, you need to apply force to the eye. And that force isn't just focal to just the cornea. Obviously, if you hit the cornea with force, that cornea is actually attached to the sclera, which is then attached to the whole globe. So you're not just measuring the biomechanics of just the cornea. You're also looking at the biomechanical responses beyond that, right? This is non-contact. Now, to be fair, like the Scheimpflug one has found a way to isolate just the corneal movements, but Brion does this non-contact, and it's able to look at elastic modulus at multiple points across the cornea, but not just that, also depth into the cornea, right? So in keratoconus, we know that there is a front to back homogeneous effect that happens because we lose those Bowman's anchoring fibers up front, in the anterior stroma. So we lose anterior corneal strength, right? And it becomes more homogeneous with the posterior cornea. So when we look at this, we really want to know what's the depth dependent strength of a cornea as well. And this can do this, but it also has applications in the crystalline lens as well. So a very cool device. The other one here is OCT elastography. We're applying a compression force to the cornea similar to like a confocal microscope, and we're tracking keratocyte movement. And what we're doing is we're calculating that movement to give the tissue modulus. And we can use this for looking at effective treatments, or just looking at, hey, is this cornea weaker than average? So normal corneal biomechanics, what you're seeing here is Brion on the left, OCT elastography on the right. Brion, we're looking at various different points across the cornea and at various different depths, and you can see that it's pretty homogeneous across the whole cornea. Whereas on the OCT elastography images, you can see that the anterior stroma is stronger than the posterior stroma, just like we would expect from all the anterior, interweaving in the front and that lamellar stacking in the back. But you get that bifurcation that's created, front stronger than back. Um, Now, when we look at keratoconus, if we look at the area in the cone region, we can see that those points are substantially uh, weaker than what we have outside of that cone area. And when we look at the depth dependent, effect, what we see is that the cornea is weaker front to back in both of these. So what we see is the biomechanical distribution and changes here. Now, what we can do with this is we can also use all this data to do multifocal or multi-factor computational modeling. So if we know the shape of your cornea and we know the biomechanics of the cornea, what we can do is we can run simulations on the cornea as to what would happen either over time in a keratoconic cornea or what would happen if we did simulated procedures on a cornea, right? Like we could say, hey, we know your biomechanics and your corneal shape. What would happen if we ran PRK on you? What would happen if we ran Smile on you? What would happen if we ran LASIK on you, right? And we can get this structural analysis and predicted effect after the procedure. So wild, wild stuff that's coming here in the future. This is the Specify software really coming out of Dupes' lab over at at the Cleveland Clinic at Cole Eye Institute. But they do a tremendous amount of work. Him, Randleman, Scarcelli, Brecken Blackburn, all these individuals who really work on these, corneal biomechanics and these modeling. And they all really spawn from, Cynthia Roberts' work as well. So, kind of things to remember. So these are the things that you want to remember on the diagnostics. So, if you got your cell phone around you, go ahead, take a photo of this. Wow, I said cell phone, not smartphone. Go ahead, just take a photo of it and ignore what I had to say there. But, these are the metrics to remember if we're looking for keratoconus. And give you a few more seconds here. Good. Hopefully you got your image there. And, what does it all break down to? Pattern recognition. Just think of this, right? It's asymmetric, it's steep, it's elevated, it's thin, it's weak, right? Keratoconus. Start thinking about that. Let's get into another thing that we like to use in diagnostics, specular microscopy, right? We can get specular illumination when we're looking at the slit lamp. We can see, the gutata in this right image here, in this patient who has early Fuchs. Well, not so early Fuchs, obvious Fuchs. But, specular microscopy does this in an automated fashion, right? It's an objective analysis of this. Non-contact gives you direct visualization of the cells, right? So, there's a couple metrics of interest. We look at CD, which stands for cell density, so the number of cells that's there. Hexagonal cell ratio or hex, which is a measurement of pleomorphism or, loss of the six-sided shape of the endothelial cell. And then your coefficient of variation, so your CV, so your polymegathism. So how enlarged are the cells, right? So here are some examples. You can see a 26-year-old non-contact lens where look at the uniformity, look at the cell density. You can see almost 3,000 cells. You can see that cell density very high. Excuse me, our coefficient of variability. What we're seeing here is that about 30, we're looking at a normal value there, right? And when we look at our hex, which is actually not available on this older system, that unfortunately we are stuck with in our office right now. But when we look at that, that's really what our normality is. But when we look at, a contact lens wearer that's been a contact lens wearer for years, this is an individual, kind of in their mid 40s. You can see their cell density is a little reduced. Their, cellular variability, not out of the ordinary though. But when we get to our PKP, but you can see in just the images here in the contact lens wearer that our polymegathism really exists, right? You can see smaller cells, larger cells if we had a good metric of a hex here, we would see that we're losing some sides here. We're seeing more variation. And as we get into our penetrating keratoplasty case, you can see that we are really losing cell density. We have a higher level of coefficient of variation, and our hexagonal cell ratio would be very different. Now, the cool thing is with modern versions of this, we get automated multi-point analysis, right? And we get tracking of the spots so that we can really track the changes over time. So you can get these graphs of progression or changes to your various coefficients. And we really, really get an ability to follow these individuals over time. So let's say you had somebody who had family history of Fuchs. Well, you could follow their endothelium over time and see how they're progressing or changing before they need treatment. If you had somebody who had, a corneal transplant, you could look at their changes over time. We know that we see a decrease in the number of cells in the cell density over time. Going from the, post-operative period up to the 5 year mark. And then again, we see a continued but leveling off of that cell loss from the 5 year to the 10 year mark. So we're seeing, a drop from an average of about, 2,700 to about 800 at the 5 year mark, and then from 800 to 600 at about the 10 year mark, or from the 5 to the 10 year mark. Let's get into infectious keratitis. This one, you get a patient that comes in looking like this, nice soupy, infiltrate there. What are we thinking here? Well, classically, we're going to pull out our culture plates. We're going to look at our agar, whether that's blood, chocolate, Sabros. We may look at, do we want to get something for kind of viral, looking at like our universal transport media. Do we want to collect a lot of tissue there with our scrape, put it on slides, use our spatula? Basically what we're going to do, we're going to submit these to our microbiology lab. They're going to go ahead and incubate them, then go ahead and tell us what we grew out, and they'll give you a report, right? So for that poor guy on the slide before us, they had a Pseudomonas ulcer, right? Now what we got to do is we got to wait for them to run susceptibility on that certain organism there, right? So they're going to go ahead and plate a whole bunch of different antibiotics, typical antibiotics that have effect against Pseudomonas in this individual and or on those plates, and then they're going to report back to us what are the medications that are likely to help this individual, right? Well, many of us in clinical practice are not going to have these culture plates on hand. They're not going to be something that we keep readily available. If we work in a cornea specific practice, we may. But this is where things have changed. PCR swabs, right? So what you're getting here, these are very easy to have in any clinical practice, whether you're in primary care, peds, anything. You can have these. They're shelf stable for a very long time. They don't need to be refrigerated. They don't need any special packaging. They don't need to be renewed that often. Essentially, what you have is a swab and a universal material here. What you do is you swab the ulcer. With this, my recommendation is to do very aggressive swabbing with that swab because you want to make sure that you're getting the material, and then you put it into the tube over here. You're going to go ahead, break the swab off, cap it, and then you're going to send it in. The cool thing about this, they give you overnight results with this. So this is PCR testing. So they're looking at various different things. So you're going to get, identification, like in this patient, it came out with E. coli and let's see here. Gosh, I can't read that from that far. But what we're looking at here, text is just too small for me. But when you're looking at that, it's going to go ahead and identify your pathogens. It's also going to look at the genes in those to see if anything that has resistance to antibiotics is identified. And then they're going to tell you the susceptibilities, not only for topical drops, but also for, IV and for oral medications. So this is a really, really intense, very, very actionable thing. And everybody in every clinical practice should have this. Two companies that run this. This is HealthTrack RX, Microgen DX. Both of them will run ophthalmology or ophthalmic panels. And the cool thing about this is you can use it for more than just cornea. We use it frequently for conjunctiva as well in our practice. Um, Now, what about if you see something like that Pseudomonas case, right? Empirically, generally, when I see a bacterial looking infection, I'm throwing moxifloxacin and polytrim on them, getting as much broad spectrum coverage as I can get. But what about those really nasty ones, like what you saw up front? Those ones, I know I want fortified antibiotics even before I get laboratory confirmation that the strain or whatever we're culturing out is susceptible to this. Common fortified antibiotic is vancomycin and tobramycin, right? Well, there is a company that creates a drop that you can keep in your office that is a fortified antibiotic, right? And it's a mix of tobramycin and vancomycin, right? Typically, when you're getting fortifieds, you got to call your compounding pharmacy, say, hey, this is what I want. And then they're going to make that up for you and then send that to your patient directly. Sometimes that can take 24 to 48 hours, right? Whereas this, you can have it in your office, you can sell it directly to the patient. It's a combo drop, it's readily available. The company will replace it for free because I believe the drops only have a shelf life of about 6 months. But once you buy it from the company, they'll go ahead and replace it once it gets to that 6 month shelf life. So very, very important, very, very helpful in these severe cases. Um, what's new, what's not in the US? PAC cross-linking. We know cross-linking from its use in keratoconus to be able to, and ectasia, to be able to stiffen the cornea, to increase the biomechanical strength of the cornea to prevent progression. Well, what it also can do is it can do sterilization of infectious keratitises, right? So this was a phase 3 study over in Europe looking for bacterial and fungal and mixed infections. And what they found was that it was just as effective. There was no, excuse me, not just as effective, but rather the proper way to say this, there was no statistically significant difference in outcomes between using topical therapy, classical topical therapies, versus using PAC cross-linking. So what they find is that this may be an alternative to antimicrobial drugs and could be used as a first line and standalone treatment for early to moderate infectious keratitis of bacterial or fungal origin. Now, this becomes very cool for those of us that work in, emergency clinics where, patients don't follow up as well. If we can give them one blast of this cross-linking where we're using our riboflavin and our UV to create that photochemical reaction in the cornea. If we can give them one blast of this of high energy, cross-linking to kill this, we may not have to worry about their level of compliance with their topical therapies. What about acanthamoeba, right? We know about that classic ring ulcer. These are two unfortunate patients that I had the pleasure of seeing. But diagnosis, we know history is the biggest thing, right? Ring ulcer, and then ex vivo, right? Corneal biopsies, right? The cultures are not very good at, giving us classic or really giving us any diagnostic ability for acanthamoeba. But there is one tool that we use for in vivo diagnosis, which is confocal microscopy, right? We can use this to be able to identify the cysts in acanthamoeba, and it's pretty pathognomonic. What we can see right here is exactly that, those acanthamoeba spores in there. Now, what about treatments for it? Well, outside of the US, polyhexidine um, got a CE mark and is available for the treatment of acanthamoeba. But classical treatments in the United States, polyhexidine, PHMB, Broline, but there is a new one that's being studied, not so new. The first one, first reports of this really came out in 2019, but this is one from 2024. But what they're looking at is miltosifine. So what we're looking at here is that this used topically ex vivo, but it was able to kill cysts and the trophozoites. So when we look at this, it's cytal for the cysts, but it needs to be at 30-fold higher concentration. But it was safe for the corneal epithelial cells in this ex vivo model that they use. So something that could be promising for the future. What about corneal neuropathy? What's new, right? Aesthesiometry is something, we hear a lot about it at NK now because of the availability of oxyrate, right? So we need to check corneal sensitivity, right? So how do we do it in clinical practice? Will we do it qualitative? Cotton wisp, right? Not really reproducible. Something that's really just a yes, no. Does it feel different between the two eyes? Not a good way to do it, right? If we want to be qualitative, though, we have to use a Cochet Bonnet to be able to do that, right? And for this, we're using these are very, very difficult to come by, right? We're using that nylon filament. It has to be in contact with the cornea to be able to get our effect, right? So, if we have a long filament, that's going to be a very soft touch to the cornea, soft force. As we shorten the filament and touch it to the cornea, it's going to be a much higher force. So if we're greater than 4 on this and, kind of in the longer area, we're normal. If we're less than 4 on the meter there, we have reduced sensitivity. And if we have 0, we have no sensitivity, right? Well, let's use this in clinical practice, right? This was a patient that was referred for scleral lenses for dry eye because they'd been refractory to multiple different interventions, right? Multiple different topicals, multiple different, MGD treatments, IPL, all these sorts of things, right? Well, I just went back to basics and said, well, let's recheck our initial findings here and let's do some corneal sensitivity testing, right? With the swab, the patient said, feels the same, feel it. So, not really a whole lot of difference. But when we did Cochet-Bonnet testing, of course, we're nerds here, so we have that in our office. But when we did that, she has reduced sensitivity in both eyes. So we started her on Cernezerman or Oxervate, and the cornea fully heals in 4 weeks, right? And when we repeat our CB testing, they're now up to 5 and 6 in the eye. So we've increased the corneal sensitivity. So a very, very cool thing here. But what's new, right? Getting a CB is very, very difficult, right? So what's new? Non-contact aesthesiometry. So this is a device that uses pneumatic micropulses to be able to measure the corneal sensitivity. So this is non-contact. It's reproducible. You can see the blue line is the force that's created with the aesthesiometer, whereas the CB is in the red. You can see that it's non-linear, right? But it's very linear with the non-contact. And what you can see is that they've even standardized and validated this so that the various different symptom thresholds, you can, say a patient has, a normal corneal sensitivity, corneal hyposensitivity, severe hyposensitivity, or actually you can diagnose hypersensitivity. So a very, very cool thing. And there's a spectrum of treatments, but we're going to talk about a couple here. Um, in corneal neuropathy, there's a lot of different things in the pipeline for topicals. So a few different ones for persistent epithelial defects that are associated with neurotrophic keratitis. You have one that's in the pipeline for neuropathic corneal pain, so your hypersensitivity, and then again for your PED. And then we go into amniotic membranes, right? Like, what's our difference between our dehydrated and our cryopreserved? Well, the main thing here is that our labeling for our dehydrated is for wound coverage, and our cryopreserved is for wound healing, right? Two different processing. Well, when we use a cryopreserved, I always have difficulty with patients tolerating this because of the ring, right? Well, there's a new version of this that's come out without the ring, and it's got kind of a sticky appearance because of its treatment that it goes through, where you just put it in the back of your contact lens and lay that over the eye. This is again a CAM, they call it CAM 360 membrane. And then our last one, what if you failed a lot of different things? How are we going to go ahead and get that epithelium to close? Well, this is where something called BMAC or bright mem anterior keratoplasty comes in. And this is something where we take a decellularized DMEC graft, right? So imagine DMEC, we're using a very thin layer of Decimase membrane, we're scraping the cells off of it. What we're doing here is we're laying it after we've done a superficial keratectomy on the bare stroma, right? And what we're doing here is this Decimase membrane. Nobody realized this, but what it has is it has fibronectin and vitronectin, variety of different, spar here, um, various different chains and various different, uh, proliferatives that allow or rather promote stem cell proliferation and adherence of epithelium to this membrane. So kind of think of it almost as a pseudo niche for promoting stem cell migration and epithelial migration across the cornea. So this is kind of the procedure. You get this fresh tissue, you decellularize it, you go ahead, do your superficial, you lay down the button because it already has its pre-trephrination. What you do then is you go ahead and lift it away, and now you have your bright mem anterior keratoplasty down, which is what you're seeing in that inferior left image here. What you then do is smooth that out. You then go ahead and add a drop of fibrin glue at the edges, and then you're going to put your BCL on. What they did an aniridia clinical trial for this, as we know that's really associated with limbal stem cell deficiency and PEDs. So they treated these individuals with BMAC in the worst seeing eye. What we find is all these individuals with PEDs reepithelialized by month one. They had no recurrence of superficial vessels. What you can see here is on the left, they're pre-op, on their post, they're post-op, but no recurrence of the superficial vessels, improvements of visual acuities at, post-op month one, no infectious, keratitis is seen. So candidates for this, partial limbal stem cell deficiency with or without epithelial defects, non-healing corneal epithelial defects, variety of different things that we can use this for. Since we're come up on time here, we're going to go ahead and take a stop here and we'll go ahead and go into some Q&A, okay? Perfect.